Good morning. That was a very long introduction. I'm sorry. I'm going to walk around a little bit on stage because as a professor, I like to make sure that I interact with the audience because I want my students to make sure, first of all, that they don't fall asleep. And I know that this is a wonderful, engaged group of people out there, but look, it's a Saturday morning. I get it. Thank you all for being here. My name is Glenn Sterner. I'm an assistant professor of criminal justice at Penn State Abington. Drove up this morning, and I must say, it is just wonderful being up here. I grew up in a small town in Michigan. Grew up on a farm, moved to Pennsylvania to get my PhD, and it's when I come to places like Penn State Schuylkill, it reminds me of home. It just has that feeling of being welcoming, being inviting, and certainly Penn State Schuylkill has been that way the entire process of, frankly, welcoming me here to be the keynote speaker this morning. So, Rosalie, thank you so much. Dr. Jones, thank you so much for your leadership in making sure that this can happen this morning. What I'm going to talk about today is the opioid crisis, why we're all here, right? But as we talk about this, I'm going to ask you some questions, and I hope that you ask me questions, and I hope that this is more of just a dialogue rather than a presentation. Because the way that we work and we address this issue is together. It's really important for me, in my perspective, that we have all this leadership sitting in this front row and throughout the entire room from across your community, from across our Commonwealth, making sure that we're addressing this in a comprehensive way. I think it says a lot that we have health, that we have criminal justice, we have treatment, we have prevention, we have folks from the county making sure that we understand all of the resources available to us through our single county authority. These are important resources for us to be here. And the more that we help us to all understand that we can, as Dr. Jones mentioned, work on this together, the more likely we're going to be able to be successful. So what are we going to talk about today? First of all, whenever I talk about this subject, I think it's important for us to not make any assumptions. So what are these things that we're talking about? What are opioids? So we'll talk a little bit about that. We'll also explore where they actually come from, and I know that our district attorney is going to make sure that we talk a little bit more about emerging drug trends. I won't cover that too much so that you can really talk about what's happening here in this community here, but I'll talk globally and more broadly about that issue. We're also going to talk about how this is affecting communities in the U.S., but also what about Pennsylvania, right? Let's talk about what's happening across our Commonwealth. And then this is something that I don't normally get to talk about, but we do have some good news to share, that there are some things that are working, right? So let's talk about those things. And then we should also be talking about some other things that are emerging, and likely the district attorney is going to probably touch on those too. So again, I'll make sure that I don't cover his talk. And then finally, frankly, we're going to talk a little bit about where you're going to get help, but you're going to hear about that throughout the rest of the day, and there are wonderful vendors that have been here to make sure that you have access to lots of opportunities and resources and treatment that we're going to hear about throughout the rest of the experience. So let's start it off. What are opioids? What are some names that you may have heard as far as opioids go? Oxycontin. What was that? Fentanyl, yes, absolutely. Heroin. You all are very aware of what's going on. Yes, we do know that there are multiple types of substances. When we start to think about them, we also hear these two different words, right? Opiates versus opioids. And so it's important for us to know the difference. We typically use those words interchangeably, but opiates are naturally derived from the poppy plant. Opioids are in some way changed by chemistry, so in our laboratories. That's the only difference here. They're essentially the same thing, but we have that small distinction. So if you see these two words, just know that people are probably talking about any of these three categories, right? First is prescription opioid painkillers. That's probably something that we are very familiar with, and they're used for legitimate pain management reasons, right? You go to the doctor, you might have a surgery. Our healthcare system might need to utilize this for your pain management program, whether that's acute or chronic pain. You might be utilizing Percocet, OxyContin, a whole host of different name brands that we come to be associated with these. Fentanyl is also another name that we typically hear more associated with the illicit and illegitimate sides of this. But really, that's also a pain management option. And so these are sometimes diverted. And these are sometimes finding their ways out into our streets, into misuse patterns where they might be utilized for not our own healthcare experiences. And so we know that these substances have found their ways into our homes and into our bodies across not just this community, but across the entire country. And that was a big issue back in the 90s that helped to drive this opioid crisis as it is today. But we also have heroin. Heroin is derived from the poppy plant. You can see three different types here. So the whiter the heroin, the more pure it is, which makes it a little bit, it makes it have a bit more strength, right? So we want to make sure that we understand that when you have a wider source of heroin, there are fewer impurities. It is actually stronger. It can actually, have adverse effects. But so can heroin that looks just like the one in the center there, which is a bit more what we would consider impure. And then we have what are considered synthetics. This is where you hear the words fentanyl, carfentanil. These are very strong substances. These are substances that are used for also legitimate means, but we typically think of them in large animal issues. So these are tranquilizers for, say, a rhino or an elephant, those types of things. So they do have legitimate means. They are entirely synthetic and created in a lab. And when we start to think about why it is that we care about the three different types, it's because of this picture right here. Heroin all the way to the right-hand, from your perspective, to the left-hand side. That is the lethal dose for someone of average body weight non-user. That's a lethal dose. Middle is fentanyl, so you can start to see just a few crystals in there, right? Whereas carfentanil, it can be just a crystal. This is roughly what it would take to potentially kill you. And so with that, we know that when carfentanil or fentanyl makes its way into the supplies of these other substances, that's a dangerous experience. You might not know what you're getting, especially if you're getting it from illicit means. You might think that you're getting heroin, you might think that you're getting an OxyContin pill, but really that's been pulled together and it's been pressed fentanyl or carfentanil. And that's an issue. And that causes you to overdose. So where do these actually come from? Well, let's first talk about prescription opioid painkillers. We know that prescription opioid painkillers come from, legitimately, our healthcare system, from drug makers. And we see, thankfully, over time, these prescriptions have decreased. This is good news. We want fewer prescriptions out there being utilized by potentially anybody, because we know that we have had a huge glut of these substances in our homes, in our cabinets, in our healthcare system. And we now see that there were some predatory experiences by some of these drug companies when they were talking to our healthcare systems, misleading them with the information that they had. And our Attorney General, as well as many other Attorney Generals, are seeking ways to make sure that they are held accountable, thankfully. But for us, practically, look at this. We are starting to see them go down, but there's still a lot of substances out there. We still need to be concerned about prescription opioid painkillers. This is why you need to make sure that when you have excess, you turn them in. We have drug take-back boxes. We have drug take-back events. You can get them out of our communities. You can make sure that they do not get into the hands of people for misuse. If you think that you might need them once upon a time or in the future, please realize that that can actually put people that you love and care about at risk. Get rid of them. What about heroin? Well, so previously, we used to think of where as a huge source of heroin. Where do we think of as a source of heroin previously? Afghanistan, yeah. So in that area of the world where there's a huge poppy cultivation, right? We know that that is still remaining one of the world's largest producer of heroin, as well as India. And we've seen that market grow over time in Pakistan, in those areas. But for the United States, our sources of heroin actually come from Mexico. And this is only recently. This is only within the past roughly 5 or so years that we've seen Mexican heroin skyrocket. It's coming to us not necessarily over land, but potentially through our United States Postal Service. The USPS, I like to say, is our world's largest drug distributor. World's largest drug trafficker. And it's very terrifying to say that. But we can pass these substances through the mail fairly easily because we have such a high volume, unfortunately. And it's happening in places just like your community here. And it's also happening, frankly, with this other substance known as fentanyl. Fentanyl comes through, again, what's the source of fentanyl originally? China. I heard somebody talking about that. Yes. So China is actually most likely the originator of most of our fentanyl that we're getting here in the United States. But it can come through these different ports of entry, whether that's through passing through Canada or whether that's passing through Mexico. The origin source is actually coming straight from China. And thankfully, we have seen the Chinese government move in a way that is giving us a little bit of hope that they're starting to more strictly regulate this issue. They're recognizing that this is a source of harm to our communities here in Pennsylvania, as well as across the entire country. And they're working together with our federal government to hopefully curtail that issue. But we still need to make sure that we're paying attention to it. And so, yes, fentanyl gets into our communities, but it doesn't necessarily always stay in that form, right? It ends up in, whether it's heroin, but now we're actually seeing it being introduced into methamphetamine. We're seeing it being introduced into cocaine. And so this is important for us because those people who might be afraid of utilizing heroin, that they may have said, I don't want to use these substances anymore, I'm going to move to something else because of my substance use disorder. They may actually be moving to those because they think it's safer. Well, unfortunately, it's not. It's not safe. None of these substances are safe because you don't know what you're getting. And this is why it's so important for us to find access to the treatment that our folks need to make sure that they address their substance use disorder, that we have the support for them both in our communities, but within our families and within our neighborhoods to make sure that they understand the resources available to us. So how is it actually affecting our communities? I wouldn't be here if you all didn't know that this was affecting your community today. You all wouldn't be here in the same way. 180 registrants. We see that there is an incredible community response to this issue. I'm aware that there is a newly formed frankly, an overdose task force, but certainly an opioid overdose task force here in Schuylkill, thanks to the leadership of the district attorney in association with colleagues at the University of Pittsburgh. That's wonderful. We know that this is affecting your community, and it's so incredible to see the leadership to come together to address this issue in a comprehensive way. As I mentioned before, we do have a little bit of good news. Frankly, this is the first time in many years that we can actually say that likely overdose deaths in the United States has decreased. Thankfully. This is preliminary numbers, but this is still pretty hopeful. But I caution us. These numbers are only happening because, frankly, we've really paid a lot of attention to it. If we let our foot off that pedal, it will go up. We need to make sure that we continue to fight, and we make sure that we continue to find access to resources here in this community, but across the entire nation. So what has led to this? In the beginning, it was prescription opioid painkillers. Most of the overdoses were coming from that substance. But then we saw an emergence and resurgence, really, of heroin contributing to overdose deaths in the United States. And then this third wave has been more so the fentanyl and the synthetics. So you can see that that has only happened within the last 2 to 3 years. And that's going to continue to rise, and it has continued to rise. These are 2017 data. 2018 shows us that prescription opioid painkiller deaths actually decreased in the United States. Same with heroin. These are good things. But fentanyl continued to rise. The other substances that continued to rise that led to overdoses? Cocaine and methamphetamine. And that's most likely because people are moving from these substances that they feel are unsafe. When really, again, I cannot emphasize this enough, that they are also unsafe substances. There is no safe illicit substance. None. Not a single one. And it's important for us to remember that because if we think that this is only an opioid issue, it's frankly not. It's a substance use issue. And the more that we treat this as a substance use crisis rather than just an opioid crisis, the more that we're going to be able to handle this as well as other future issues in our communities across Schuylkill, but across Pennsylvania and across the nation. Important to note is that this has affected men more than women, but we have seen rise in women overdosing from these substances over time. We also see that this was actually not a really young person issue in the beginning. This was hitting people from 35 to 44 in the beginning the most. This is not typical of substance use trends that we've seen previously. Why might that be? Go ahead.
People of the age group, like they're getting hurt.
Uh-huh.
Going to the doctor, as people age,
Exactly. That's precisely it. So they had access to health care. They were working. They were getting access to the substances that were driving this crisis in the beginning, OxyContin, Percocet, those types of experiences. That's why we likely saw it rise first. And then we saw it move into this other really strange age group that surpassed that, 45 to 54. Again, these are people who are typically working in manual labor, issues associated with getting access to health care. So these two age groups, not typical. Not what you would typically think of as dying from drug overdoses typically. You would think of teenagers, maybe early 20s, and frankly, some of them have caught up along the way, which is unfortunate. But this is an issue that affects everyone, across all age groups, across any community, across gender lines, across any racial background. This is an issue that affects us all. And frankly, it has hit some places harder in the beginning, over time, but it has reached every single community across our nation. This is showing you the progression of overdose deaths over time across the country. What do we see? Where do you see some of those really dark red spots emerging? What's that? West Coast, we see some of that on the West Coast. Rural spaces, yeah, absolutely. Where else do we see it? Take a look at where Pennsylvania is, right? Pennsylvania, Ohio, West Virginia have led the nation in overdose death rates for quite some time. That's not a race that we want to be winning, right? That's not something that we want to be proud of. Well, in 2018, we were the highest number of overdose deaths by actual numbers in the country. That's terrible. We were number 3 in overdose death rates. Now, that was 2017. In 2018, those numbers have gone down, and we're still waiting for the final numbers to let us know exactly where we shuffled out. But unfortunately, we've seen other states, for example, like Missouri, increase in their overdose death rates in the past year. So this isn't going away, and it's affecting different communities in different ways. And this is an illustration. You don't have to read this illustration. This is merely so that you see that this is an analysis done by my good friend and colleague Shannon Monnet and Carrie Rigg. These are all the rural counties across the country. You see the different colors? Each of those colors are different substances that are leading to overdose deaths. You see a lot of different colors up there, right? And there are certainly different trends that emerge across our country. Important to note that not every community is alike. And that's why it's important for us to understand what types of substances are being used here in Schuylkill, which is what we'll be hearing about. It's important for us to understand what resources are available to address those substance use issues because not every plan that has been put into place to address fentanyl in, say, here in the Commonwealth of Pennsylvania is as relevant for those in other states where prescription opioid painkillers may still be leading the way. And so we need to treat this as a crisis that we can address in, frankly, local solutions, based in local work. So how is it affecting Pennsylvania? Well, again, we have surpassed, as I mentioned before, overdose death rates in the nation, unfortunately. We are winning that race, and hopefully we're going to slow that down. These are the overdose deaths by county in 2017. We're still waiting on the maps for 2018. But we see some obvious trends. On the western side of the state, in very rural places, we have seen this really hit Pennsylvania. This is not something that many of us really expected. The only reason that I got into addressing issues of substance in our communities was I was doing my PhD at Penn State up at University Park. And I was out talking to communities, small communities. You know, as I mentioned before, I come from a farm town in Michigan. And so I was working in communities there, working in communities here in Pennsylvania, in towns of several thousand people. I come from a place of 500 people, so even smaller. But these places were talking about this. This was back in the early 2010s, so 2013, 2012, talking about some of the great things that were happening in their community. They were happy to talk about that, but they were also talking about this emerging issue of they were noticing that people were overdosing of heroin in these really small towns. And I said, I had never even heard of anybody dying of heroin in my hometown. That has since changed. But I'd never been in places where it was so prevalent in these really small farming towns. And I said, there's something here. We have to address this. And frankly, this is where we've seen some of the highest rates year after year after year increase in overdose deaths. But it's important to note that our urban spaces also have caught up to our rural areas. Urban and rural spaces have been the hardest hit by the opioid crisis. Again, not places that you would think that would have too much in common when it comes to substance use issues, but this is one of them. And so it's important for us to know that, again, this can happen in any community here in Pennsylvania, but frankly, across the entire country. So we've seen some good news. Even back in the change from 2015 to 2017, some communities either were slowing that death rate or even decreasing, which is nice to see. But when we start to think about what has contributed to our death rates in Pennsylvania, let's take a look at these substances, because again, we have to know what people are dying from in order for us to address it. We see a lot of change, a lot of variation here in 2015. Some people are dying of fentanyl. Most of it is heroin at this point. Some prescription opioid painkillers in the middle of the country, the Commonwealth. And then there are other illicit drugs, things like methamphetamine, those types of experiences. But by 2016, we see this infiltration of fentanyl into the supply, and then by 2017, it's blanketed the entire state. Fentanyl became the largest contributor to overdose deaths in the Commonwealth of Pennsylvania by 2017, and it is hit everywhere. So if you think that you're immune, you aren't looking at this map correctly, because it is hitting everywhere. But we, again, have some good news. We see a spike, but we also see a peak. We are seeing that this is decreasing in Pennsylvania as far as overdose death rates. But this is death rates. What doesn't that tell us? What people are actually using, right? It doesn't tell us, it tells us that, thankfully, we're keeping more people alive so that they can get into the treatment that they need so that they can live healthy, productive experiences, right? We know that. But unfortunately, this doesn't tell us how many people are actively using it. That's really hard to measure. And we likely can't get an accurate measure of that, but we know that we cannot take our foot off the pedal here in Pennsylvania. We cannot think that we are done fighting this fight, and we have to make sure that we continue to address this issue in a comprehensive way. So why do we actually care about, beyond overdose deaths, why do we care about what substances you're actually utilizing? Why do we care if you move from prescription opioid painkillers into heroin and potentially utilizing fentanyl? Why do we care about those things? Because some of those effects of your use patterns can actually be worse over time. And that's exactly what the research that I and other colleagues are showing. That when we talk to people who are active users, they attribute, yes, they have some negative effects of their use to their prescription opioid painkiller use patterns. Lots of disruption in their family. This should not be a shock to anybody who has either been touched by this disease or has been affected by this disease in any way. This is not something that is an exciting experience to go through, right? It disrupts our families, it disrupts our communities, it disrupts our individuals' lives. But we also see some important things over here on the right-hand side. Missing work or school, lost a job or dropping out, trouble with the law. We know that this then increases when we start to talk about their heroin use, sometimes doubling in the negative effects that they're indicating. That, yeah, they are, once we see that progression in their use pattern, that they're having more trouble with the law, that they are losing their jobs, they're having more problems with their families. So if we can find ways to intervene between that time when they are using prescription opioid painkillers to heroin, we have the potential to disrupt some of that negative consequences. We have the potential to make sure that we lessen this burden on the individual as well as our families and our communities. And so that's why it's so important so that you know the resources that are available to you as well as your friends and family members and community members across all of Schuylkill, but across all of the Commonwealth of Pennsylvania. So what is working? What's working? This is working. It's really exciting for me to see an audience that is here and interested in this topic. It was really great to see leadership being willing to be here in the audience today and here to talk about the stuff that's going on locally. That's what's working. When we see communities pulling together to make sure that we address this in comprehensive ways, we know that this is working. We also know that increasing access to treatment is working. The new model to ensure that people have greater access to medically assisted treatment is getting people into more treatment across Pennsylvania. The PACMAT model is going to be evaluated by Penn State, by myself as well as some other collaborators to make sure that we can think about how it is that we can, first of all, understand the effects of getting people into treatment and hopefully quicker. But also making sure that we can find ways to expand it so that it's just not a well-kept secret here in Pennsylvania, but frankly, something that we can lead the nation on. We know that treatment works, and there are many pathways to treatment, and that you can be just as healthy as anybody else once you work through your treatment process, even though there may be some issues with relapse, there may be some issues along the way. Never stop finding ways to make sure that you support your loved ones who are trying to get into treatment. I hope you make sure that you recognize that that's not easy to always do, and I know that. But frankly, it's one of those things that when you talk to people who've made it through and they have had that support from you as a person, that you never stop loving them, that you never stop standing by them, that doesn't mean enabling them, but it means making sure that they have access to the resources they need. They are so incredibly thankful on the other side of it all. I hear that every single day when I talk to people who've been affected by the opioid crisis. We also know that this is working. It was great to hear that naloxone is going to be accessible here in our community locally just this upcoming week. Naloxone works. Naloxone works. This should not be a surprise to anybody. So for those of you who don't know what naloxone and Narcan is, it is a nasal spray. It can also be an injection. This is not a new substance. This is something that's been around for 40 years. It reduces the effects of an opioid overdose. This is important for you to know. This does not reduce an overdose associated with methamphetamine. It does not reduce the overdose associated with any other substance other than an opioid. To be fair, If you even suspect that somebody is overdosing of an opioid, it will not hurt them if you put that into their nasal cavity and spray that in there. It will not hurt them if they have another substance in their system. It will not hurt them. So make sure that if you even suspect that, this is an opportunity for you to save a life. So make sure that you, first of all, get access to it. You can get it for free, but you can also get it through the standing order from our physician general. Thankfully, Dr. Levine has made this available to any member, any person in Pennsylvania that wants access to it. Many times it's covered by your insurance, sometimes it's not. And for those who can't afford it, we have these abilities to get access to it either through these drug take-back days and many other communities, not drug take-back days, through naloxone distribution days, or through many other opportunities through local organizations to get this training that you need in order to utilize it. So make sure that if you see somebody who is having an overdose, get it into their system. It will take roughly 2 to 5 minutes for that person to respond. The other important note here is that if you have somebody who's overdosing from fentanyl, it may take more than one dose. So it's important for you not just to hold one dose on your person, but you may want 2, potentially even 3, right? To make sure that if you know that you have somebody at risk, make sure that you have that on you. And importantly, call someone as soon as you administer, and frankly, even before you administer. Make sure that somebody is calling 911. Call those EMTs, get them to the local healthcare system. Make sure that you can work through the warm handoff process so that they can get into treatment after they've been treated at the emergency room, to make sure that they go straight from overdose to stabilization into treatment. There are options. Make sure that you have that capacity. But you can't do that if you're not talking to somebody on 911. You are covered by the Good Samaritan law. You cannot be charged if you are helping somebody out who's in a fatal crisis. Make sure you call 911 and make sure that you do not leave that person to die. Actually, I'm going to go back just before this, before I show you a little video that we have to talk about the work that we're doing at Penn State University. I can't emphasize enough that those numbers before that I showed you that are going down are probably because, in large part, due to the life-saving medication known as naloxone and Narcan. That's not enough. We are not going to Narcan and naloxone our way out of this issue. We need to make sure that we have access to treatment. We need to make sure that we're addressing this in a systematic, comprehensive way, making sure that we're partnering with law enforcement, making sure that we're partnering with treatment, with our healthcare system, with our colleges and universities to make sure that we have the most up-to-date understanding of this issue. And frankly, we need your help. It has to be with people who see each other every single day, whether in your homes, whether on your sidewalks, whether in your streets. You have the capacity to make a difference, and you can make sure that people are not dying. But not dying isn't good enough. That's not good enough. We need to make sure that we think about how it is that we get people so that they are healthy. And this is the way that we're going to do it, by developing coalitions, by talking about these things, getting access into treatment, having this conversation. If we don't talk about it, we will never address it. And so, frankly, I'm really honored to be part of Penn State and the Consortium to Combat Substance Abuse because we are talking about it. We're talking about it across the entire Commonwealth of Pennsylvania. We have initiatives here at Schuylkill. We have initiatives at Penn State Abington, at University Park. We have them all over through our extension system. We are addressing this issue. And frankly, it's been really exciting to be able to share what we're doing here through our WPSU public access and public station, who has pulled together these incredible sets of videos to talk about this issue, a podcast, and they're also putting out a special on the opioid crisis on what it is that we're doing here in Pennsylvania to address this issue. And so I want you to take 5 minutes and hear a little bit about what that looks like for us here at Penn State.
The deaths from the opioid crisis have far exceeded the deaths at the peak of the HIV epidemic. If this were an infectious disease and it were killing numbers of people. We would call that an epidemic as well.
What happened in 2009 was in every state in the nation, drug overdose was the #1 reason for unintentional deaths. So you had a shift of that becoming the major reason why people in our country are dying.
The first time he was caught shooting up, so I didn't put me in the night.
Years ago, I never thought anything about it because I didn't think it would really affect us. And now, my friends are losing so many kids right now these days. We've probably had in my little group 10 people who lost their children in the last 2 years. So I think it's pretty bad. It's destructive. And now it's very personal to me. When my son first started on what they call Heroin, I wouldn't talk to anybody. I'd sit at home for days, hours, in my room watching TV. I felt as soon as I walked out the door, I walked to the grocery stores, oh, there's Brian's mom. Did you see what her son did? I felt like everybody knew.
Stigma is one of the most serious components around substance use disorder from my perspective. I think of my friend now, Lisa Bum. She didn't really want to talk to people about her son's substance use disorder. She didn't know who to turn to. The way that we currently think about substance use disorder as a moral failing is incorrect. And so when we understand this and we really understand the humanizing perspective associated with this epidemic, the more likely that you, yourself, might actually change your perspective on who these types of people are that are affected by this disease.
When you use drugs or alcohol on a consistent basis, what can happen is you actually have changes in the brain. And those changes in the brain can be long-lasting, so you can have them for months to years. And what may seem like a choice or a bad decision may actually, unfortunately, be the brain's chemistry working against that person. So medication-assisted treatment thinks about addiction in the way that it affects the brain.
The issue with addiction in particular is that there's no other illness where the disease itself is as stigmatized as the treatment. So even if somebody's willing to accept that addiction is an illness, they are less likely to accept methadone and buprenorphine as legitimate treatments for this illness. Or patients who have diabetes. If they were to suddenly stop their diabetes medicine, it would absolutely be seen in the emergency department with complications of those illnesses. And the same thing would happen if somebody were on methadone maintenance or buprenorphine. If they stopped the medicine, they would experience sickness. So I think that it's a multi-pronged challenge to get people to both accept addiction as an illness that requires evidence-based treatment, and that the evidence-based treatment isn't in and of itself dirty in any way.
I can't talk to my family because they'll probably judge my son. When I speak to community initiatives, my goal is to change your perspective on substance use disorder. I am somebody who is engaged in this work very heavily across the entire Commonwealth. Probably thought pretty poorly of people who were engaged in substance use. But what changed my perspective was when I got to meet some of these other folks who have been really affected by the opioid crisis. With each story that I hear, with each interview that I conduct, with each person that I meet, the more I tend to realize that this really is something that can affect anybody from any background at any time. We have to make these issues and concerns known, and we have to make sure that we are not embarrassed by these issues. This is a disease, this is not moral failing. And that's why we continue to fight every day. This is something that can be treated and has been treated and will be treated. That there is hope in recovery, that there is hope through the process of support, that there is hope through grief, that there is hope, period.
There is hope. And each of you in this audience probably know somebody who has been affected by this crisis. I can't imagine that you don't. I know that too many people continue to die from this disease. I know this. I see those numbers. I see those statistics. I know that individuals and families and communities are continuing to be affected by this. I know this because I talk to people literally every day. I talk across this entire Commonwealth to try to address this issue. I know that treatment works. I know that there's opportunities associated with the work that you all are doing, but I also know that it takes a lot of work. People are tired, and I get that. And sometimes people are even tired of hearing about this issue, and I get that. But that's not an excuse. I think of the woman that you saw in that video, Tricia, and I think about Pamela, her daughter who she lost, and I can't help but think that we all know somebody else that we've also lost along the way. That needs to continue to motivate us. That needs to drive our passion to make sure that people across the Commonwealth, people like Lisa Bum's son that you also heard about, get into recovery. And I believe, I know, that when we address this in a comprehensive way, when we work across all of our capacities in each of our communities, that we can do this. I believe in community. I believe in you. And so right now, I want you to do something for me. I want you to turn to the person next to you, hopefully it's somebody that you don't know, and just introduce yourself. Because the way that we address this issue is making those connections. The way that we address this issue is having this conversation. And the way that we address this issue is working together. Many hands do make light work. And frankly, this conversation that's happening right now gives me hope. So thank you all for being here today. There are some resources that I want to make sure that you are aware of. If you yourself, and we're going to hear some testimonials later, but if you want to share your story, if you want to share it publicly and find ways to make sure that you're helping to impact others, go to shareyouropioidstory.com. That's an initiative that we're working on with the Department of Drug and Alcohol Programs in Penn State and a whole host of other organizations to help share the stories of those who've been affected by the opioid crisis, as well as, frankly, we're moving into any substance use issue across the entire Commonwealth and frankly, across the nation. And if you ever have any questions, I'm available. I can talk to you. I can at least do my best to get people to connect to you who might actually know the answer, because I certainly don't know all the answers. And I would love to hear some feedback and as well as opportunities that you all have, because the more that we share those opportunities, the better that we're all going to be. So thank you so much for letting me speak with you this morning, and I really appreciate your attention to this really critical issue here at, frankly, Penn State Schuylkill, but across the entire community here in Schuylkill. Thank you.
We have some time to take a question or two,
yeah.
Dr. Sterner.
Absolutely. I'm happy to take questions.
Does anyone have?
The former mayor of New York City gave a significant amount of money to Pennsylvania to fight the program, the drugs. Can you say where that money's went, or?
Yeah, so for those of you who are not aware, the Bloomberg Charities have provided some money to Pennsylvania as well as several other states across the nation. This is being distributed and utilized through a process that we're all aware of, but certainly has been driven through this organization called Vital Strategies. And so they're still in the process of finding ways to make sure that this gets out to the communities that need it the most, and getting it into the hands of organizations that can actually utilize this to impact the opioid crisis, as well as other substance use issues. So the short answer is it's still in the process, but I do know that they are working diligently to make sure that it's getting out there. Okay.
Good morning, Doctor.
Good morning.
Just a comment. I think about 26, 27 years ago, just in my humble opinion, it looks like the horse was let out of the barn with Purdue Pharma. Now, looking at that video multiple times, which I have, and seeing the doctors in the white coats and the pharmaceutical representatives coming forward and saying, touting the effectiveness of this, and then fast forwarding 27 years further down the road and seeing hundreds and hundreds and hundreds and hundreds and hundreds of thousands of people dead because of this, leads me to sort of question what was known from the beginning. I get it, people misuse stuff, I understand that. Probably one of the most compelling stories, and it's out of Pennsylvania, but it's one of our great neighboring states of West Virginia, Senator Manchin's state, and the story about what happened in Mingo County with bituminous coal. Where do you get a county so small with maybe 1,000 or 2,000 people, studying it for 3 years, getting millions and millions and millions of prescriptions in there and deaths in the great state of West Virginia. And then, you could ask any over-the-road truck driver that's been doing it for a while. You see mom and pop pain clinics popping up everywhere. Virtual. I have this, I have that, then you're prescribed. Kind of leads you to believe, where are we with everything? Why is this happening? And that's, in my estimation, a very big cause, direct cause, and something that needs to be addressed somehow, because it's so evident to the common man to see that.
Yeah, absolutely. So, the comment is really, frankly, something that I'm frustrated with too, right? So we know that there was inappropriate and misuse of information to sell these painkillers to not just doctors, but also to patients. We know that this happened. And thankfully, we now have the ability to address that issue in a more comprehensive way. We are working with law enforcement to do that, right? We have our Attorney General who is taking this head on. We also have our district attorneys who are engaged in this fight as well. We also have other systems that are helping us to make sure that this doesn't happen again. The Prescription Drug Monitoring Program, the PDMP, is in every state except for, I believe, one at this point. And most states, at least for Pennsylvania, we connect across many states in our neighboring areas to make sure that they talk to one another. So these data systems that track who is giving out prescriptions, whether that is a physician or a pharmacist, and who is getting those as far as a patient goes, we now can track better and understand who's getting these things, right? Who is giving these, and how much are they giving, and what are the thresholds that we should probably be monitoring to make sure that if there's a flag in that system, you should probably go talk to them and address that pain clinic, right? So we do have tighter restrictions around those things, but I will say this. It is not important for us just to control supply. At this point, we're beyond that. We are beyond only controlling supply. It has to be a control of supply, it has to be an access of treatment, and it has to continue to be prevention around getting people to utilize these substances in the first place. All three of those things have to be in place at this point in this crisis because we're too far along. So we have to make sure that we are also addressing that if we know that pain patient, acute or chronic, has potentially a dependency and maybe even a substance use disorder, that they get into the treatment they need. Because if not, what we're finding is that with the institution of these PDMPs, these monitoring programs that are cutting off supplies, people do then tend to go into the illicit markets, and that's not safe. That's not safe. And so how do we make sure that we think about this from an entire patient perspective rather than just a pill delivery system, right? We have to make sure that our patients, that our family members are being put first, not just the data that's behind reducing supply. Oh.
Yes.
Thank you.
Good, thank you.
And I would like to get your opinion about THC, marijuana, as perhaps a gateway drug. We just had a terrible accident. That was a substance that was on board this individual. I'd like to hear your comments.
Yeah.
You sow the wind that you reap the whirlwind.
Yeah, so thank you for coming out to this conversation. The coroners are an incredible, important aspect of addressing this issue because they provide that link between the healthcare system and the criminal justice system that we so desperately need. So thank you for being so attentive and making sure that you're hearing this from the community's perspective and taking that leadership on. With regards to thinking about THC and marijuana, so the concept of a gateway drug may be something that we like to think about, but it isn't always necessarily there. Right? We know that substances don't always lead to another substance. So if you use marijuana, you're not automatically going to start utilizing another substance thereafter, right? But we do know that when your judgment is impaired, you may utilize other substances. So that's what we're really concerned with, is more the concept of polysubstance use. So when you have availability, when you have this availability through typically informal means, and the research that I have done as well as others have shown and we've published has indicated that most of the time that you're just sharing these substances with your friends and family, and that you're getting access to it not through like what we would consider a dealer at the first time, but typically because your friend or your family member or your older brother, and frankly that's typically older brother or sister, that's where we're seeing a lot of it, because they just happen to have it on hand. And so this continues for me to indicate that we need to address supply. With regards to THC and marijuana, this is complicated. We don't know the exact effects of what's going on because, frankly, it's so messed up between the federal, local, and state level that we can't really get our hands around understanding thresholds for when somebody is too impaired to drive. We haven't developed mechanisms to make sure that we can assess these things in ways that will be comprehensive. We do know on the federal level it is illegal, but in some states it is legal for both medical uses, but also for recreational uses. And then there are some places that it's only available for medical uses. And so we right now are in a weird time in our country where we're trying to figure all this all out. And frankly, we don't have the availability to make some of these decisions because it's so dispersed, and frankly, people are doing what they want no matter what, and we're not enforcing laws, and we're not enforcing policies, and we're not developing new policies because we're afraid of the ramifications of them. So my end rant, the end of my rant is that we don't know that answer right now, and unfortunately, we're not going to probably know that for the next several years until most likely it becomes legal at the federal level.
Hi, I have the question, and another speaker might be able to cover it. I've helped more than one young people into rehabs. My son just recently relapsed, but they told him he couldn't stay because he didn't relapse enough. He had used one time, and then 5 days later, it was very light, but he still relapsed, and he still felt that he should go. 8 days after he went in there, he was discharged because he didn't use enough. Now, I know some of it is insurance, and some of it, it goes all the way around. But what can we as a society do to say these young people that want help, they go in and they get the help, and they get help, he was dual diagnostic as well, but they had to rush him through, and now he's not comfortable taking any kind of medication because he doesn't have that same person to be able to go speak to. So is there anything they're claiming because the beds, funding, what is going to make that a better option? What's going to keep these young people? I say young people because that's how it affected me. But they're not getting that time. They're not getting that space. They're not, and I'm at a loss. Both young people that I tried to get into rehab, they came for them the next day. I prayed that they stayed at my house for that one extra day. Now, they did come get him, but like I said, they discharged my son 8 days later. He's doing very well, thankfully.
I'm glad that he is doing well. Yeah, so first of all, I want to say Thank you for sharing that, right? That's not always easy to share in a public forum. And second of all, I'm really glad to hear that your son's doing well. But I am sad to hear that he has had some issues along the way with regards to getting treatment. This is a story that I hear frequently. So what can we do when we start to think about the issue of treatment and getting access, right? First of all, I think it's really important that you connect with your provider, right? Like you have these open conversations about, so what are the barriers and why were these decisions made? Sometimes when we put that all in the hands of the individual patient, that might not be the best way to do it because that person may not have the capacity to have those conversations and advocate for themselves, right? So we need to help be an advocate for that person. Work with that person through their experience as best as we possibly can. So work with that treatment provider and make sure that you ask some of these questions of this person who's sitting right here and is actually going to be talking about some of these treatment options as well. The second is making sure that you're involved in talking about some of the policies around how this is handled at the local to state to federal level. So making sure that you're connecting with your elected representatives, your commissioners, your state representatives, senators, those types of people, to make sure that we have this conversation around the limitations associated with our policies and procedures for insurance. When people have cancer and they relapse, we, first of all, are sad about that, right? And then we also want to make sure that they have access to get the treatment that they need if they do relapse. And that is essentially automatic, right? We don't put a limitation on that. My mom went through breast cancer and relapsed with another type of cancer as a consequence. She didn't have to worry about if her insurance was going to cover that. And that's the appropriate thing to do, right? When you have a medical condition, you should be able to get the access to the treatment that you need according to the coverage that you have. That's not the case for everybody's insurance. And the more that we work with our elected officials to make sure that we help these insurance companies see that, the better. And so it's important for you to connect and advocate, utilize your son potentially as a case study that says, this is what happened, this is what's going on, how do we fix this together? How do we develop these policies that will work together for us all? And then overall, it's important that you do talk with your son, right? It's important that you find that opportunity to talk with the person who you're supporting through this, recognizing that relapse, unfortunately, is part of this process. And it may take a couple of times of getting into the right and appropriate treatment for that person in order for them to get into recovery. We know that relapse is part of recovery. And we shouldn't hold that against that person. We shouldn't hold that against that process. And that we should help walk them through as much as we possibly can and be supportive and love them through their recovery to make sure that they know that this may take whatever pathway it takes in order for them to get to the place where they're successful. And so continuing to make sure that you are happy and excited for his recovery and that the fact that he is doing well probably tells us a lot. So there are lots of options that we can take, frankly, when it comes to treatment.
So I'm very, very interested in if you can give us some good resources for anti-stigma work, which we're trying to do in the community now.
Mm-hmm. Yeah, so this is a little self-promoting, but shareyouropioidstory.com. We have 20 videos. We're about to release another 5 that you can utilize in any way, shape, or form. You can show them. They're all available publicly as opportunities for you to open up these conversations. There are continued resources that we have, depending on what you need, whether that's information about the disease of addiction, whether that's about understanding substance use disorder more broadly, some of the factual-based experiences. There are lots of opportunities through the Department of Drug and Alcohol programs and frankly, through your local single county authority. There's lots of incredible information that they have available to them that you can utilize to help dispel some of those myths, to help dispel some of those untruths around this issue, right? Because that's a lot of this is dispelling myths. But I typically find that statistics don't change perspective. They don't. I can tell you all the numbers that I want. And frankly, that's what I was doing for a while. And then I had this mother come up to me when I was speaking out, doing some of those statistical analyses, discussions out in Hershey, Pennsylvania. And this woman afterwards says, I need to talk to someone because my son has a substance use disorder and he's going to be incarcerated soon. And I don't know who to talk to because my family is going to look at my son differently if I tell them. And my friends and family are probably going to think that I'm a bad mom if I admit this to them. And so I don't know who to talk to. And the more that we can reach out to those people who are going through this experience, the more that we can take those individual experiences and help people realize that this can happen to anybody at any time, in any community, in any family, the more that we can utilize those personal narratives to help change perspective, that we can show that hope is possible, that recovery is possible, that even though you might be experiencing grief, you can work through that, and we can help to find ways to make sure that this doesn't happen to other people, that we can help you through your grief process. Those are the stories that we need to continue to focus on. And the more that we can spread that message, the more likely we're going to be able to get people into treatment faster, happen to have those conversations with the loved ones and friends that we know that we need to have that conversation with, so that we can address this issue head on, rather than in the shadows or being afraid to even speak another word about it. So yes, there are lots of resources, and I'm absolutely happy to connect you to them. Thank you so much.
Thank you very much, Dr. Sternman. As a token of appreciation, just have a little gift from both Lehigh Valley Hospital Schuylkill and Penn State Schuylkill. Thank you so much. And thank you, audience. Great questions.